I think every test in medicine has a certain sensitivity and specificity, and it's never 100%. And so, can I envision a scenario where a nuclear blood flow study fails to detect some blood flow? Of course. There's always going to be a certain error rate. I think part of the way we combat that is we do multiple tests, each of which have a very low error rate. And if they all say the same thing, we're about as sure as we can possibly be of the diagnosis.
Jim Siegler here, back for part 2 of our 2-part series on brain death in the Brainwaves podcast. And who you just heard was Dr. Joshua Levine, who you heard along with Dr. Mike Rubenstein and myself last week as we talked about the history of the semantics behind brain death. From Mollere's Coma de Passé in 1959, to Robert Schwab's Death in Spite of Cardiac Action, to the 1968 Harvard Ad Hoc Committee's report on brain death, to our current standards of practice when we encounter a patient with suspected permanent failure of the brain and the brainstem. In this week's installment, we'll aim to cover the shortcomings of brain death as a medical term. What does it take to make this, quote, diagnosis? And what is the guarantee that you're not letting somebody die who might otherwise have sustained a reversible brain injury? We'll get to that in a minute, right after this short message from our sponsors.
Support for this episode of Brainwaves and the following message was brought to you by Audible, the internet's largest collection of ad-free audiobooks. If you are enjoying the episode so far, you might like to hear My Stroke of Insight by Jill Bolte Taylor. It's the intense story of a neuroanatomist who experiences a right-sided intracranial hemorrhage and recovers to tell the tale. You can get this audiobook and listen to it in its entirety in just 5 hours by going to audibletrial.com/brainwaves. That's audibletrial.com/brainwaves.
How do we determine brain death in an adult?
First, we rule out any confounder. So there are certain prerequisites before you even go down the pathway to make sure that the diagnosis is not confounded. And there are certain confounders that can mimic brain death. So, for example, extreme hypothermia or barbiturate intoxication can mimic brain death. Paralytic medications and medications that dilate the pupils that are often given together, for example, during a code can mimic brain death. So once you've ruled out all of those confounders, you have to make sure you have a mechanism that's sufficient to account for whole brain function being lost. And if you can do those two things...
The patient can't simply roll in via ambulance unresponsive and you not know why. You have to know that the patient overdosed on opiates and has a major hypoxic ischemic injury, or they had fever and they have laboratory evidence of encephalitis. Something has to be recognized as the proximate cause of brain injury, and that type of injury has to be something known to cause irreversible failure of brain activity. Only then can you go into the formal, protocolized neurologic examination to determine brain death.
Those two things, then you go down the protocolized determination, and first you establish that the patient is in a coma. Essentially, we make sure that there's no response to any external stimulation other than reflexes that are not mediated by the brain, such as spinal cord-mediated reflexes.
One of the big issues that happens that I see frequently is when in the chart is written, patient withdraws from pain. And it's this classic kind of, you have non-neurologists who are examining a patient and they're squeezing a person's toe and their foot dorsiflexes, which we know as triple flexion. If I see that in the chart, I'll take a safety pin and I'll touch the dorsum of the foot with the safety pin, and the person will dorsiflex their foot into the pin. And that's a spinal reflex.
And there are a myriad of strange, spontaneous movements which don't necessarily indicate the patient's awake or alert, or that they feel pain, or that they're even conscious. You don't even have to touch the patient. These movements just happen. There may be ocular microtremor, cyclical dilation and constriction of the pupils, slow arm lifting or head turning, spontaneous posturing, small twitches, or even myoclonus following massive anoxic brain injury, and even whole body shivering, which may look to family and friends like the patient's feeling pain, which can be alarming to the friends and family. And nobody wants to imagine that their loved one is in pain. Even more confusing is when family or friends think that these movements happen because they were speaking to the patient, as if it were a response to a loved one. But really, these movements just happen. It's important to exclude these types of behaviors that may be spinal or reflexive in origin, because you want to be able to identify what movements are conscious and volitional. And that's the first part of the brain death exam, is assessing for cortical responsiveness.
And then we test the cranial nerves in as much detail as we can.
Are the pupils reactive to light? Is the corneal reflex present? Do the eyes move appropriately with an oculocephalic maneuver or with cold caloric testing? Is there a cough or a gag reflex? Each of these cranial nerve assessments have to be tested for.
And then finally, we formally test to see whether there's apnea. Traditionally, an apnea test is done by actually removing the patient from the ventilator. Usually, a cannula is placed down the endotracheal tube to allow for passive delivery of oxygen. And this is to prevent severe desaturations during testing, which might lead to cardiac instability.
These are the three major criteria for brain death that were published by the American Academy of Neurology in 1995. And they serve as acceptable medical standards which the 1981 Uniform Determination of Death Act depends on. And the Uniform Determination of Death Act is more of a guide than a statute. It stipulates that physicians may determine death in accordance with national standards, like those put forth by the AAN, or regional standards or local medical standards. So it's up to the leadership at each hospital to determine how these tests are performed and interpreted. Here's Dr. Rubenstein again.
In 2008, David Greer put out a paper in which he and a few others evaluated the variability of brain death determination at the 50 most highly reputed hospitals in the U.S. as of 2006. This was 1 year after the 2005 AAN update to the 1995 guidelines on the determination of death, and most surprising was how even these top centers did not comply with the AAN guidelines. A third of hospitals allowed the determination of death in the absence of a known cause, and only half required that sedatives and paralytics had not been recently used. Almost a third of hospitals permitted a death determination only after one physician's exam. Of the 71% of hospitals that required multiple exams, most said 6 hours was a long enough interval between exams. 3 of the 41 hospitals who responded didn't even have institutional guidelines on determining death. The apnea test probably had the most variability, even though it's one of the 2 or 3 major exam criteria for confirming brain death. 87% of hospitals required there to be no respirations from the patient. 71% mandated the apnea test to be aborted if the patient becomes unstable. Fewer than half required the patient's PCO2 to rise above their baseline after the test begins, which we do to confirm that the patient is not ventilating. So even after the revised guidelines of 2005 from the AAN, not even the 50 most reputable hospitals in the country were utilizing the criteria appropriately.
At Penn, we've been using for a couple of years now an on-ventilator apnea test where we deliver continuous positive pressure but don't ventilate the patient sufficiently to get rid of CO2. So we basically set the minute ventilation or the tidal volume to be less than that of dead space. So we're not effectively ventilating the patient. And although not proven, we feel that this might be a little bit safer because it allows for the delivery of continuous positive pressure, which keeps the alveoli open and allows for better oxygenation. And it also doesn't cause the blood pressure shifts that you often see when you sort of immediately remove positive pressure from the patient.
Although it sounds relatively straightforward to test for apnea, it's not always so easy.
Obviously, we don't want the patient to become hemodynamically unstable or unstable from a respiratory standpoint. That can happen, and the test is aborted immediately when instability occurs. And it's partly clinical judgment and partly establishing firm cutoffs for aborting the apnea test. When an apnea test is done on the ventilator, the cardiac pulsations are often sufficient to trigger the ventilator, and so the sensitivity of the sensor in the ventilator has to be adjusted appropriately. And the machine is going to give, at least in the way we do it, a few breaths to the patient, and those can't be confused for spontaneous breaths. So what I ask the respiratory therapist to do is to call out every time the machine is delivering a breath. And by looking at the tracings on the ventilator screen, you can also see whether the patient has initiated a breath on their own as well.
Sometimes patients may actually arrest during brain death assessment, which can be extremely confusing. For all intents and purposes, the provider is forced to treat the patient as if he or she is still alive, but without a heartbeat or breathing lungs, and therefore the provider is required to resuscitate the potentially dead or, quote, brain dead patient. In some patients who don't arrest during the apnea test, the test can also be misinterpreted because of a variety of reasons. The ventilator may be overly sensitive to water droplets that rest inside the tubing. These droplets may move back and forth because of forces generated by ICU machinery, or because of the air coursing over them. And even such a small force generated by water droplets could trigger the ventilator in a way that looks like the patient is still triggering his or her own breaths. Often, the critical care team would try to adjust the ventilator settings in order to avoid this confounder, but this can be missed by an untrained eye. Changes in transpleural pressure from the beating heart may also trigger the ventilator, so often providers may entirely disconnect the machinery and look for chest rise. Later, they'd confirm with an arterial blood gas to make sure the patient isn't ventilating. Making the apnea test more of a challenge is that you can't test for apnea in certain scenarios. Consider the patient who's not even breathing to begin with. How do you confirm brain death in a patient who's on ECMO? This is where you need an ancillary test. The EEG, like the cerebral angiogram before it, is an ancillary test that's used to determine whether there is any cortical function. You'll recall that an isoelectric or an unresponsive EEG was part of Robert Schwab's original criteria for, quote, death in spite of cardiac action, and later it was part of Guy Alexander's criteria for neurologic death, as well as the Harvard Ad Hoc Committee's criteria for irreversible coma.
Well, I think the ancillary tests are helpful when, they're one of the kind of the main issues that we have sometimes is the inability to do the apnea test. And so when you have an inability to do the apnea test, some of the ancillary studies come into play because you would like some more supportive evidence.
Today, we rely on these ancillary tests when our neurologic exam is limited. And sometimes the exam may be confusing. The patient may have the spontaneous movements as we discussed before, or they may even appear to withdraw from pain.
The whole concept of death, whether you're talking about from the heart stopping or the brain stopping, has to be subjective at some point.
But subjectiveness doesn't equate to unreliability.
I will point out that in cardiac death, that's made by an exam as well. It's made by someone's ears in a stethoscope listening to a chest. And I'm not sure why that would be less subjective than a neurologic exam.
Think about it. If you're feeling for a pulse, you might miss it if you don't know where to palpate, or if the patient's hypotensive, or if they may be even in shock. If you're listening for a heartbeat, you might miss that too, for who knows why. Maybe the diaphragm on your stethoscope is inverted, or the patient's body habitus could be limiting, or they could have cardiac tamponade, which might also prevent you from feeling a pulse as well. The neurologic exam comes with its own limitations, like those for the cardiovascular assessment, but it's still a very reliable and validated assessment for determining irreversible brain damage. Here's Dr. Levine again.
The couple of cases that have been reported of quote-unquote reversible brain death, I believe one was in a pediatric case and one was an adult case. And at least in the adult case, death was declared by a competent neurointensivist, and so it was probably done correctly, and it seems like there weren't confounders. That patient did not go on to make a dramatic recovery. They just regained a little bit of function of the brainstem. So we can't ever be 100% sure. But I think in large part, the whole concept of death, whether you're talking about from the heart stopping or the brain stopping, has to be subjective at some point. Clearly, when the heart stops, there are parts of the body that are still, quote unquote, alive, but the organism as a whole ceases to function.
Have you ever encountered a situation where you wanted to diagnose a patient with brain death and it was difficult, or the family was challenging to deal with, or there was just something that wasn't quite clear and it made the diagnosis tricky?
Oh, absolutely. Don't forget, I've been practicing for 30 years. So much of this...
You look so much younger than I would imagine.
I grew up in a lot of this. So, I was in medical school when the, Uniform Determination of Death Act, I started medical school right when that came out. I think from a family standpoint, it is absolutely an issue. And again, that's because of the difficulty in the use of the term brain death as opposed to determination of death by neurologic criteria. And I also think that people sometimes throw out the term brain death much too loosely. It's extremely rare that we're making a determination of death by neurologic criteria in patients. By far and away, the majority of patients that we see that are where further care is futile are not brain dead. People throw that term around too loosely, and there's such strict criteria, and it's just such a small percentage of patients.
So brain death is a legal construct and not an actual state of being until you've made that diagnosis. So a patient could possibly or potentially be brain dead.
And it's really not, it's really not a diagnosis, it's actually a state.
But it's not a state until you've made that determination.
Correct.
But you do have to do that exam before you can declare somebody dead by neurologic criteria. And
Correct.
So how do you tread that line with families when they know that something disastrous has happened and they don't know exactly how well their loved one is doing? How do you approach them and say, I need to examine him to determine if he's dead?
Again, those are the rare cases. What I do when I'm at the bedside and there's family, my response to them is, I think your loved one has already passed, and I'm going to do a test to determine that that is actually the case.
I feel like it's not uncommon when I'm in the hospital and working in the ICU to see a family who is in complete disbelief that their loved one has died or has experienced neurologic death. And when I come in to say I'm here to evaluate this patient, they refuse to believe that their loved one is dead based on my neurologic exam. Maybe because I'm young. Maybe because I look like I'm...
You're just so young and good looking that people just don't believe you.
It's true, I don't have the serious face. They end up fighting me back.
Oh no, that comes up all the time.
Yeah.
And that's a very sticky situation. I mean, doctors are protected, and ventilating a dead person is again abuse of a corpse. And so once you make that determination, if the family continues to not understand, you need to go to the next step, and that may be getting an ethics consult, calling the ethics committee so that somebody can come and talk to the family, having pastoral care there, doing other things that can help them understand. But they can't block you from doing that.
Despite all the controversy of the semantics of brain death and the potential conflicts of interest that may have arisen out of this medical necessity, there is a lot that we've gained from it. Because of death by neurologic criteria, because of ways that we can artificially support the human body with mechanical ventilation, hemodialysis, transcutaneous pacing, or ventricular assist devices, whatever we're using, because we have these technologies, transplanted organs may remain viable for long after the donor has died. And these technologies have benefited hundreds of thousands of people in the last half-century. In spite of all the criticism we've shared about brain death, it really has made a huge difference to a large number of people. And it will continue to make a difference in the years to come. Again, I'd like to thank Drs. Mike Rubenstein and Joshua Levine for joining me on our segment again this week. For more information, please check out brainwaves.me. We've got a lot of great content on the blog entry from this week and from last week, including links to the 1968 Ad Hoc Committee report and some other great articles for you. There's also a nice outline of the sequence of events as well. This week's episode was produced by me with the help of Mike Rubenstein. Music was courtesy of Chris Zabriskie, Hyson, Kai Engel, and Lee Rosevear. I'm Jim Siegler for Brainwaves, signing off.